Good afternoon. Thank you all for having me and the opportunity to speak to you today. So I'm going to take a crack at physical activity as it relates to weight loss maintenance and potentially other health-related outcomes. And so I like to think about this in a way that I think we need to understand this. You know, we've been talking a lot about physical activity today. Body weight is part of this discussion. But I like to think about, you know, what are we ultimately trying to get to? And what we're ultimately trying to get to is some level of health, and that can be widely defined. It all depends on what we're talking about. It could be mortality or morbidity, but it could be very, very specific as we define that. And I think that we've been thinking about this from is it physical activity or is it obesity perspective? And I actually believe that that's the wrong approach. And the reason I think that's the wrong approach is that physical activity is a behavior and body weight is basically an outcome. And when we sit here and think about what is it that we're going to change, what we're targeting is physical activity or potentially eating behavior with the hope that it moves obesity or another health-related outcome. And so I think that if we're going to argue, is it physical activity or obesity, it's actually almost a little bit self-defeating. And the one reason that I think it's a little bit self-defeating is that one pathway by which physical activity actually may improve health is through its effect on body weight. And I know Bob talked about the effect that we can see. Others have talked about that today. But if we don't let obesity be part of the discussion, we're probably going to miss the overall big benefit that we can get by trying to target multiple things from my perspective. And this is why. These are data from the Look Ahead trial. These are baseline cross-sectional data that we published a few years ago. And the Look Ahead trial had 5,145 individuals in it, and these were all type 2 diabetics. And these are pre-randomization, so we did a max exercise test on them, and we looked at a variety of other things. And what you're seeing here is we have actually, we're showing here the fitness category, and these are quintiles. So this would be the highest 40%, middle 20%, and lowest 40% based upon fitness. And you can see that up here as well. And what we're showing here in each of these different, the square or the diamond, this would be individuals who would be classified as overweight or class 1 obesity. This would be class 2 and class 3 based upon BMI. And what you see is as you go from the most fit to the least fit, there is basically an increase in the odds of having a high HbA1c. However, when you look then within those categories of BMI, there is no significant difference. So if you were to look at these data, you would suggest that BMI doesn't really matter when it comes to HbA1c control, that it's really fitness. The more fit you are, the better off you're going to be with HbA1c, and it really doesn't matter if you're overweight or all the way through about a BMI of 45. However, when you look at the odds of having hypertension, defined by either taking medication to control blood pressure or meeting the criteria for systolic or diastolic blood pressure, and you look across those fitness quintiles, the picture changes a little bit. Of course, you go from high fitness to low fitness, and the odds go up, but there's also separation within those BMI categories. And so when you think about this, I don't think I can take from these data right here saying it's just about fitness and physical activity. Because if I did that, I may actually be minimizing the effect that body weight might have on hypertension. And so to maximize the effect on hypertension, absolutely let's focus on physical activity and fitness, but let's not ignore the potential independent effect that body weight might have on hypertension as well. And so if we're thinking about patient-centered outcomes and maximizing those outcomes, I think both of these have to be part of the discussion, and we shouldn't be excluding one over the other. These are data across time at 4 years in the Look Ahead trial as well. We had repeated fitness tests on individuals, and this is looking at the change in fitness from baseline to 4 years, and we're looking at the change in HbA1c. What you're looking at here is we had 2 intervention groups, a diabetes support and education group, which technically served as our control, and an intensive lifestyle intervention group. And here you see the combined data the diabetes support and education, and the intensive lifestyle intervention group. And what you're seeing is you go across these fitness changes. So this would be a decline all the way up to a 10% increase in fitness. You see almost like this nice dose-response relationship. Kind of goes away a little bit here, but there is still a dose response occurring, at least at this point. But remember, this group right here, if you know anything about the look ahead, was targeting weight loss as the primary. And so you have to be a little careful because there was a lot of emphasis put on weight loss. This group is actually interesting to me because this is a group that we saw just a couple times a year. They had standard care and said, you know, go about your business. Look at that nice dose-response relationship. The more fit you are, the more likely it is that you're going to have an improvement in your HbA1c, or the bigger the change in fitness. And that's after we adjusted for age, gender, weight change, and diabetes medication use to the best of our ability. So likewise, when I say let's make sure we don't, not think about weight when we're thinking about this, if we were to take a person who has type 2 diabetes and intervene on them and say all you need to do is take your medication and lose weight, we're probably minimizing or not maximizing the effect that they would get on that intervention if we ignore physical activity. Physical activity and fitness need to be part of that discussion when we're trying to treat diabetes. So if you take an example of that would be if you see a primary care physician or an endocrinologist and they simply prescribe you metformin, you're not going to get the same effect or maximize that effect as if they prescribed you metformin, for example, and got you more physically active in addition to that. So we have to be part of that discussion when it comes to maximizing these effects. But I want to go beyond what we typically think about. And again, it's not to say that one is more important than the other, but I also want to make sure we don't push aside obesity when in fact we need to think about it at times. Because we typically think about mortality and more traditional forms of morbidity, heart disease, cancer, other things. But what about these physical function measures? What happens when you look at physical function? When you look at physical function, this is self-reported on a self-reported scale, and we use a couple different scales here. And you go from normal weight all the way through obese class 3. You can see that it kind of drops off the table right here. And it drops off the table when you go from overweight to obese in both situations. And this line that I've drawn across here is basically the clinical threshold by which one would say you actually have a disability limitation or you have a functional limitation that you're concerned about. And so when it comes to some of these measures, obesity does matter, and physical activity needs to be part of that, but we can't say it's not, that obesity shouldn't be talked about. And I think this is very apparent in some of the work that was done by Steve Messier. And these data are from individuals, older adults with NEOA. And you take a look at a variety of different measures, and what he did was he actually had people basically lose weight with diet and exercise or go on an exercise-only regimen over a period of, this was 6 months in this particular study. And what you see is absolutely the exercise improved these outcomes. But exercise combined with weight loss improved them even more. And I think we have to think about that. Yes, we can get the effect, but how do we maximize the effect? And it's something we need to consider. Additional work by Messier over 18 months on the WOMAC score shows exactly the same thing, that if you get a bigger weight loss, you get a bigger effect on some of these functional measures, but exercise by itself will give you a nice benefit as well. And so I think that we can't say it's one or the other. I think we have to say it's part of a package to maximize health benefits that are probably very important for the patient. So as I think about this, there's a variety of pathways by which if you take a person who is overweight or classified as obese, that physical activity as a behavior may be very important in terms of their outcomes. And this is where I do think physical activity has a big, big impact because the pathways are multiple. We know that from work by many of the people in the room and others who are not here with us today, that physical activity has been shown to have associations with health outcomes across a variety of measures. We also know that physical activity, the pathway by which this may happen may be through fitness, and that may actually be what's potentially moving some of these health outcomes. But this pathway here is also very important, that if we move physical activity enough, we might start to move body weight, or more importantly, adiposity, or even potentially preserving or increasing lean mass. That may improve this. And what's important to me is that there actually might be an effect here, and this may go the other way, but I think the line is more this way. The physical activity may also start to change dietary behaviors, which may also start to play into this pathway. So I think we need to understand, where is it that physical activity is going to increase or improve these outcomes that are of interest to us. So I really think that physical activity is important for, part of the weight loss package, but I really think it's really important for the maintenance of weight loss once you have actually lost the weight. And many of you have seen these slides before, but we've shown this over a decade ago, where we put about 150 individuals through an 18-month weight loss program, comprehensive. These are secondary data analysis of that, where we looked at how much activity they did on average over that entire 18-month period of time, and classified them into these three categories, and then looked at their weight loss trajectories. And what we found, not for the first time, but one of the early basically longitudinal trial data, was that these individuals doing much higher levels of physical activity actually did a little bit better here, but continued to lose weight after 6 months, and then basically maintained it over the next 6-month period of time. And that dose of activity here was about 280 minutes of physical activity a week. And if you look at lesser doses, sure, they did well, but the weight is starting to come back on here, and clearly these folks here lost less, and this is the more kind of lost weight, regained the kind of weight when there's no activity involved. So it's really important in the maintenance of weight loss, I believe. So we fast forward about 10 years, and we did a completely different trial. And these, again, are secondary data analysis on about 170 individuals. And what we've done here is we've separated, the line colors represent how much weight they lost at the end of 24 months. And the group you want to pay attention to is the group that lost over 10% of their weight by the end of 24 months, and that's the blue line right here. And then we plotted physical activity against that. And what you see is all the groups actually, no matter where they ended up, had an increase in physical activity, but the only group that they had this 10% weight loss was the group that was able to maintain it over time. And that's very important. And this was of the magnitude of about 275 minutes above baseline when we take these calories and convert them basically into minutes of moderate to vigorous physical activity. Very similar to what we found before. But we do have to admit that both of those studies were based upon self-reported data and not objectively measured data. So fast forward a little bit, and in 2014, we actually have published now data based upon objectively measured physical activity using a wearable device. And what we did in this study is, these are secondary data analysis of a larger clinical trial that we published in JAMA. But what we did was we actually used 10% as a clinically meaningful weight loss. And we asked the question of, if we separate people into whether or not they achieved and then maintained a 10% weight loss, how does their activity patterns look when we do that? So you see here that this group, for example, would have not lost 10% by 6 months and would have continued to not make that goal at 18. This group did not make the goal and then eventually made the goal. This group made the goal but regained that weight, some of that weight. This group made the goal and continued. I want to point something out here. This 7% right here, these are the late losers, is what we call them. There are people that say, well, don't worry if people don't get off to a good start because they're eventually going to catch up. Well, both of these groups would have been people that didn't do well early, and only 7% of the overall sample that didn't do well early eventually started losing weight long term. So if they don't get out of the gate early, they tend not to get out of the gate, or very few of those people do that. So we have to be careful about saying, oh, just wait, they'll eventually catch up. Most people don't eventually catch up. So what did the weight loss trajectories look like? And we published these in Obesity in November of 2014. These are just the weight loss trajectories. And the white line is the group that lost 10% of their weight at 6 months and maintained it at 18 months. And that's a pretty impressive weight loss, folks. That's about an 18% weight loss sustained over the course of 18 months. This is of the same magnitude as what you would see with a gastric band, maybe even a little bit better. So a lifestyle program can be effective if it's able to do this. Here are the physical activity data from, these are objectively measured physical activity. And what you see here is the change in moderate to vigorous physical activity, represented at minutes per week. in bouts that were 10 minutes or greater in length. So they had to meet the moderate to vigorous, greater than 3 MET level, and sustain that for at least 10 minutes to be counted here. And what you see is that blue line clearly is a much higher amount of physical activity adopted, and while it comes back a little bit, it actually stays really pretty high, to the point where it's at about 1,200 MET minutes per week. And that's very high. These are the data for bouts that are actually less than 10 minutes. So these are the bouts that you do a minute here, you do a minute there, you do a minute here, you do a minute there, and you don't quite see the same trajectory. You don't see that big spike for the most part. And we really didn't, and when we put these into regression models, this didn't predict long-term weight loss at all. This fell right out of the model. Only the 10-minute bout stayed in the model. And here's the 10-minute bouts. What's really interesting to me is that for the first time, we've been able to look at light intensity physical activity as a predictor of long-term weight loss maintenance. And what you see here is this is the group that lost the most, this blue group right here. They actually had a slight increase in light intensity physical activity that was then basically sustained over that 18-month period of time. So it wasn't like individuals took their light activity and converted it over to the moderate to vigorous. That didn't happen. They actually increased their moderate to vigorous, but they also increased their light activity. And those are the people that were most successful. So our interventions should be informed about what do we target. We should be targeting both of those behaviors in order to potentially improve long-term weight loss outcomes. But in the few minutes I have left, I do want to, and so first and foremost, the objective data support our self-reported data, that this high dose of activity is probably important, or it's really important. And I want to say, I didn't put the slide in, but we published a paper back in about 2010 where we actually looked at, instead of using 10% weight loss, we used 5%, 7%, or 10% weight loss, and then tried to look at behavioral variables, including physical activity, that predicted. Physical activity did not predict 5% weight loss at 24 months. It did not predict 7% weight loss at 24 months, but it was the single most important predictor of 10% weight loss at 24 months. So it seems like if you want to get to the bigger weight losses and sustain them, activity becomes more and more important as you go forward. So what about variability? And a couple other speakers have hinted at this, and these are data from the Midwest exercise trial that Joe Donnelly and I and a number of others, Jim Hill and others, worked on. And this is 16 months of supervised exercise, 45 minutes a day, 4 to 5 days a week at about 70 to 75% of VO2 max over 16 months. And these are the individual responses of women. And there was no recommendation to change diet. We weren't able to detect changes in diet, but that's just probably because the measures are not so good. But in this case, half of the women gained weight with this exercise intervention, half of the women lost weight with this exercise intervention, and there was great variability in those who gained and those who lost with the same exercise intervention. The question is, why is that? What's going on? There's a lot of things, and I'm very interested in trying to understand this. And so one of the things that I'm interested in is, we said, well, maybe it's something with eating behavior. And I know that some of the mean data say there's no real change in eating behavior with exercise. But we brought people into our laboratory on 2 occasions. These were women who were overweight or obese, and they were sedentary to start, and we brought them into the lab twice. One time they sat for 45 minutes, the other time they exercised at about 75% of their max heart rate for 45 minutes. And then we had some stuff going on, and then we gave them free access to food. And we were drawing blood and saying, okay, you've given us some blood, you can go ahead and eat. Well, what happened was we found half of the women ate more on the day they exercised than on their rest day, and half of the women ate less on their exercise day than on their rest day. These are different people. I'm not saying it's a cause, but I'm also not saying we should dispel this. There might be things going on where if you tell someone to be physically active, that may actually stimulate hunger, and in others that may stimulate a satiety effect. It may just be, hey, I exercised, I can eat more. Hey, I exercised, I shouldn't eat more. It could be a lot of things. We need to better understand this in response to exercise. So one may induce weight loss, one may induce weight gain. And it's complex. I'm not going to go through all this, but it's very complex. And we need to understand all the different pathways that go into play here and understand how those pathways affect the health outcomes that are of significant interest to us. So I'll end with these last couple of real quick slides. I also am very interested in patterning, and we can talk about this in the open discussion. Is it really total, or is it how you get there? This is 60 minutes of moderate to vigorous physical activity. That's the moderate line right there. 60 minutes of moderate to vigorous physical activity. This is 60 minutes of moderate to vigorous physical activity with 3 10-minute bouts within that 60 minutes. This is 60 minutes with 1 30-minute bout within that 60 minutes. Very different patterns, and they may give us very different responses. And that means that if exercise, for some reason, stimulates satiety, I want to turn the system on as much as possible. If exercise stimulates hunger, I don't want to turn it on quite as often. How we match this is very important. It's precision medicine. How do we get to this? And so I just leave you with this. I know we talked a lot about sedentary behavior, but maybe we need to put some warning signs on these things that we sit on all day long. Thank you for your time, for the NIH, CDC, and everybody else who made this all possible. Thanks.